This is HealthCall Online, the place for extended versions of interviews you hear in our weekly radio broadcast, the HealthCall Radio Hour, and now heard on stations around the country in national syndication. We're going to focus today on menopause and what many women don't know about menopause. You can't escape it. It's going to happen. And so are some of the challenges. It can be difficult to find the right treatment for symptoms, and even recognizing the symptoms can be a problem, causing many women to suffer unnecessarily. So let's learn more about that and get our arms around it. Talking to Dr. Bruce Dorr, he's an OBGYN and also the senior medical advisor for a company called BioT. We'll talk about that in just a minute. He now directs his practice more to the functional care of hormone-related issues. So, Doctor, welcome. Thank you for being here.
Thank you so much for having me. I take it as a highest form of compliment to be on a program and with an individual like yourself. It's a blessing.
Oh, you're too kind. So I want to start with, let's start with the clinical definition of menopause and why that is misleading.
Well, the American College of OBGYN's definition is that the menstrual cycles have stopped for a year. And it's usually associated with many menopausal symptoms. But in general, it is misleading because there are many women that have menopausal symptoms before their periods actually stop. And so that can be a year, that can be years leading up to that going on. So many women have confusing symptoms, and there's it depends on the text and who you want to refer to, but there are as many as 40, 60, even 80 different symptoms associated with menopause. And this can be cardiac type of symptoms. This can be gastrointestinal type of symptoms. And they're still having periods, so they kind of assume, well, I can't be in menopause. So they go to cardiologists, they go to gastroenterologists, they go to other specialties thinking that there's something wrong with them. And they come to me and I'm like, hey, I'm like the Walmart of gynecology. I can fix all of these things going on, and I can help you with all of those. And they're all associated with menopause, or can be.
So this period of premenopause is called perimenopause.
Yes.
It can start, I'm reading, as early as the 30s for some women and 40s for others. What is the professional impact this has on women in the workplace?
Well, women, BioT, a company that I'm associated with, did a study of women in the workplace. It was a little over 1,000 women aged 50 to 65. And they surveyed them as far as their symptoms and how these symptoms are impacting their job. And 87% of them said they were not comfortable in bringing it up with an employer. And in fact, 17% of them said they would even consider leaving their job over how severe these symptoms were in their workplace. They felt like they wouldn't be supported, and it was affecting their cognition. It was affecting their job performance, and they were just unfortunately too embarrassed to really bring that up with the employer, and they would rather leave or quit the workplace. This is like 1.7, almost 2 million women, if you add it all up, that would leave their job over bringing it up with an employer.
That's a lot of skill and experience lost in the workplace for something that could be managed. And, I get that. I told my wife about the interview we were going to do, and she said, heck no, I'm not telling my employer that I've got menopause symptoms. Right. So, yeah, I see that problem. You bet. So let's talk about some of those symptoms and that may not be recognized. You ticked off some categories there. Let's walk through them. So the physical symptoms, I think everybody's familiar with hot flashes, but what else?
Well, certainly night sweats, and that impacts sleep. And you may know yourself, if you don't sleep, the rest of the day is shot. And that is in your cognition, that's in your certainly job performance, that's in fatigue or feeling sleepiness, but it also leads to increased feelings of anxiety. And one of the very common symptoms of menopause can be palpitations, or feeling the heart beat fast or just heavy, or being aware of that. And that is a sign associated with anxiety, but it's also associated with menopause. So you get those confusing symptoms. And I would see these people. I'm actually board subspecialized as a urogynecologist. It's called female pelvic medicine and reconstructive surgery. So I would see these people that would come into me with urinary incontinence. You know, babies, I always say every single day, there's nothing fair about being a woman. There's nothing fair about being menopausal. But
Right.
I would see, and my career is kind of an ever blooming business because either women were trying to get pregnant or they're trying not to get pregnant, or I was fixing everything that their babies and the pregnancy did to them. So
Right.
it's a blessing, but it's not fair to women. But women would come into me with their incontinence, having seen a cardiologist for these palpitations, a psychiatrist for their anxiety, a ENT or sleep specialist for their sleeplessness, or a gastroenterologist because they were bloated or had other signs. And I would say, hey, I can fix all of these things, including your urinary incontinence, by talking and going over hormone replacement therapy or helping you with these signs and symptoms.
So during this perimenopause and the menopause itself, I understand what's going on here is you're going through wild fluctuations in hormone levels.
Yep.
And that's creating a lot of these challenges. Estrogen obviously affects a lot more than our reproductive organs. Tell me more about that.
Yeah, so estrogen has over 400 different receptors all throughout the body, to bones, to your brain, to your heart, to joints, to your skin. So not only do you see changes in how you physically appear, but you also have these changes in how you're able to cope, how you're dealing kind of at the same time with kind of sassy teenage children, which tends to happen right at the same time, with aging parents that stress the situation a little bit more. So women right around this perimenopause to menopausal time are not only dealing with these ups and downs of their hormones, they're also dealing with significant life changes to their parents, to their children, sometimes to their spouse, because yes, guys are not always understanding. We don't go through menopause, but we have this gradual decline in our testosterone levels. And certainly women also have a gradual decline in their testosterone levels, which is not talked about as much as estrogen. But we then are not feeling as good and maybe are not then as supportive to our wives when they're getting hit at the same time.
Oh, man, let's walk down that road just a little bit further. What do guys need to know? How can we be more supportive?
Yes. So us guys need to understand that, you know, some days they may have great hormones, energy, and what do I want to say, understanding for what is going on in our worlds, and other days they may be so tired that they may be so foggy that they can't have that same level of energy or understanding. And again, it can fluctuate one day to another. And these, like I was saying, can be both physical signs and symptoms, but it can also be emotional signs that are going on also. So to be understanding that, yes, one day you may have one set of symptoms and the next day it may be a whole other set of symptoms that you can be concerned about. So just to be understanding through that. And again, like we were talking about, it's not just these symptoms, but it is also, like we were saying, job stress and job performance, because most women, to be able to survive in America these days, well, they've got to be out there in the workforce, and they don't have time to be not feeling their 100%.
So what is there about medical education that allows me to go to my doctor and say, look, I'm not feeling right, something's not right here, and they can't provide a solution? Do doctors learn about hormone management?
Well, this is the real travesty in America, and it started in 2002 with something called the Women's Health Initiative. It was a massive undertaking looking at hormone replacement therapy, specifically a drug called Premarin. Premarin stands for pregnant mare's urine. It was 30 different, and it still is 30 different horse urine estrogens, the best studied, the best promoted and marketed drug almost ever. And so they studied it, and when women take estrogen for hormone replacement therapy, to keep from getting uterine cancer, they have to take a second hormone, progestin. So estrogen builds the lining of the uterus, progesterone breaks it down. If you just take estrogen, it can give women uterine cancer. Unfortunately, the combination of these two drugs together in one convenient pill form led to an increased risk of heart attack, stroke, and breast cancer. And so it's what I called then the dark age of hormone replacement, because the general medical world, when they got wind of that, said all estrogen, all progestin, all hormones were bad. And so 80% of women came off of their hormones. And in that same light, the medical world and medical education for hormone replacement therapy stopped, because all of the academic centers said, we're on board with that everything was all the same. So over 50 to 60% of trainings in my field stopped. So this education, let me back up. 80% of that education stopped. So now 60% of OBGYNs have no knowledge or know what to do for hormone replacement therapy. What they have education is prescribing antidepressants or other kind of not as what I feel legitimate and as effective therapy. I'm kind of an old guy, so I was there when hormones were king, and so I know all about them. And I continued because I knew, looking at that data, that there were right hormones, there were right ways to give hormones there, and so it's about the what I call the 5 rights of medicine. And I'm sorry, I'm kind of going on just a little bit here, but it's that you want the right drug to the right patient, delivered the right way and at the right time. And unfortunately, horse urine estrogen, it's not the same as far as what's supposed to be in us. And this progestin, it's not the same. And similar is different than the same. And that's what BioT therapy is about. That's what bioidentical, or what we like to refer to more as isomolecular. It's the same thing. When you put the same thing in us, the lights come back on.
Right. So this bioidentical is, as the name sounds, it is the same chemical compound. It is identical to what is in our body. It's synthetically produced, but it is identical, is my understanding. And
Exactly.
this can be delivered. And this can be delivered in a couple of different ways. Now, people may be familiar with compounded creams, but the BioT product is different. Tell me about that.
Well, unfortunately, the general medical world is not as accepting. When we talk about bioidenticals, it has this connotation that there's not as much regulation or as much validity as a branded pharmaceutical that you get at your grocery store or pharmacy. So what is different about BioT and what we promote, although we are an education and promotional company, it is about education on hormone replacement, but one of the big emphasis is something called pelleted hormone replacement for both women and men. And again, it's the same stuff that is meant to be inside us. And a pellet it's a manufactured pellet that is under what they call a 503B compounding or manufacturing guideline. So unfortunately, back in 2012, there was a large compounding pharmacy on the East Coast that had a fungal contaminant in the steroids that they were prescribing. And over 700 people were ill, and over 70 people unfortunately died of this fungal contaminant that they had injected in their spine. And so the government came in, and it was the Health, Security, and Safety Act of 2013 that gave designation and regulation to compounding manufacturers so that there was a guarantee, an FDA inspection for their purity and quality and manufacturing. And that's the compounding facilities where BioT gets their pellets from. There are not as regulated compounding pharmacies for creams, for pills you put underneath your tongue or troches, and they're not held to that same manufacturing standard. And it gives a what do I want to say, a negative or less regulated connotation depending on who you're using for these bioidentical hormones.
So there are, however, accreditations for compounding pharmacies, and I get
Yes.
they may not stand up to the FDA level of scrutiny, but there are accreditations, and people do successfully use the compounded creams.
Exactly.
The advantage of the subdermal pellets is what?
Well, so a pellet, it looks like a small little grain of rice. And so it's delivered in our fat just underneath our skin. The body surrounds it with blood capillaries, and then every pump of your heart, in comes estrogen and testosterone. So that's how we were meant to get our hormones. So for women, the blood flows over the ovaries or over the adrenal glands, in comes estrogen and testosterone. And so every pump of the heart, in it comes. With higher pumps of the heart, you get more. The pellet acts the same way. It goes underneath the skin, body surrounds it with blood and a blood capillary network, and then every pump of the heart, in it comes. It's like giving you a brand new 18-year-old testicle in your backside, from the male perspective, or a brand new 18-year-old ovary from the women perspective. And so it is the same stuff delivered the same way. When you do a cream, somewhere around 40 to 60% of us can't absorb it through our skin. Or we have got great skin. We look like Brad Pitt or Eva Longoria or whatever. And so in comes more hormones. So some people will super absorb through the skin, or they don't absorb through the skin. That's the beauty of a subcutaneous pellet, is that I get those hormones in there. What I have to figure out, though, is what is that right dosing.
Oh man, I'm glad you went there. So that's where I have seen people have a lot of challenge. Is it's kind of an art, sort of a science, right? Your prescriber has to listen and carefully read your symptoms and how you respond to get that right mixture. Is that correct?
I'm sorry, did you call me Picasso?
I guess I
Is
did,
that
yeah.
it? Huh?
That's what
Am
it
I
is.
an artist? I'm a
You're an artist.
gynecologic.
You're an artist.
I'm a gynecologic artist. That's
There you
what I
go.
like to think of myself as. You are exactly right. So in all of medicine, and again, BioT has a computer program that helps guide practitioners to the right dosing. We get it right about 90% of the time. You never know if somebody just needs a little bit or a lot. So in general, go low and you can work your way up. So yes, once this pellet goes in, can't take it out. So my philosophy is I go in general a very low dose. As long as my patient understands, I may not get there right away with relief of your symptoms or where I want you to be to improve and help your health of your brain, your bone, your heart, protecting you from breast cancer or prostate cancer, those kind of things that go on. So you're right. In general, people do better by going slow. And that's true if I'm giving them a bladder medicine, if I'm giving them a blood pressure medicine or anything like that. You don't start out at the highest dose. You start out at the lowest dose to see how this patient will react. And so if a patient tells me, Dr. Dorr, I pass out when I take half of a Benadryl. Okay, you are getting the lowest dose that I ever give so that I don't have that negative result. And unfortunately, not everybody is trained, to understand the nuances in patient care and patient dosing. And that's what we try to teach and train our providers with BioT.
How often should I be tested once I'm under treatment to see if my levels are appropriate? Are you looking at saliva or blood values, or are you going more on the clinical observation and report of the patient?
Well, it's a little bit of both because there's safety and validation in both ways that you're suggesting. But in general, what we do once a pellet goes in is that we do follow-up labs in either 4 or 6 weeks, and then I see them a week after those labs. And so I have a combination of knowing where the hormone levels went to and a validity of where their symptoms went to. When you look at disease, so all the stuff that either hurts us or kills us starts with hormone loss. For us guys, that starts in about our 30s. We lose about 1 to 2% of our testosterone every single year, leading to problems for our brains, our bones, our hearts, prostate cancer. Mm-hmm. Same thing goes on, but there's this bigger cliff that happens with menopause and the loss of estrogen for women. You can't rely, because everybody has a little bit different salivary glands, on salivary levels when we're testing how the body and the brain are responding to that right hormone level. You can measure hormone levels, but there is a brain response. It's called the FSH or LH, follicle stimulating hormone, luteinizing hormone, and you can't really measure that out of salivary levels really at all. And so looking at blood, the blood gives me a better response looking at that. And so when I look as far as how the body is responding, especially, so we're going to do women as an example. Some women, their right dose of estrogen, where the brain and their body says it's okay, is maybe an estradiol level of 40. And for other women, it's 120 or 140. So that's why when I go to a pharmacy or when I go to a grocery store and the FDA has given me 1 dose of a gel or 1 dose of a patch, for some women, it's way too much. And for other women, it's not nearly enough. So the beauty of looking at levels and what I can do with pelleted therapy is I can see exactly where their symptoms are. I can see exactly where their levels are. And this is all about precision medicine. It's about targeted therapy for every individual patient. So I don't have one-stop shopping. It is figuring out what you or your wife are specifically and not generalizing it to most of the population.
Yeah, I think you're right on the money. I've talked to so many doctors who say you have to treat the patient and not the lab test. The lab test is not your patient, right? Exactly. Right. So tell me about, I'm going to start this stuff at age 40, age 50, whatever. Am I going to be safe to be on this product all the way out to my life expectancy of 94?
Well, as long as you want to feel good, we know that from the data is once we start losing hormones, and there was a good trial back in the early 2000s that looked at women and hormone replacement therapy. It was actually oral hormone replacement at that time. We knew from that data, and this is looking specifically at bone strength data, osteoporosis data, it was something called the PEPI trial. But we knew that within 2 years of women stopping their hormone replacement therapy, they became osteoporotic.
Wow.
When women continued it, they kept the bones of what they were their whole lives. And, what are the negatives? So we know there's negatives when you put horse urine inside you. We know there's negatives when you put birth control pill-like synthetic progestins inside you. But when you look at putting inside the body what was meant to be there, there's no, strong data. As long as you stay within correct dosing and the right delivery, there's no data saying that you're doing any harm. And we know this as a gynecologist, I've had to remove and put young women into menopause early. We know those women, when they undergo menopause in their 20s or 30s, they triple the risk of early dementia, Alzheimer's disease, osteoporosis, heart disease. And that's what happens to a menopausal woman. So to say, okay, well, yeah, once you hit 50, go ahead and lose your hormones and you're fine to age and get all these things, it doesn't make any kind of sense to me. And if you continued with the same hormones inside you, okay, I can't make people live forever. But what good is it to live if you can't go biking, if you can't walk the dog, if you can't make your breakfast, if you don't understand where you are or who your son or daughter are. So it's about the quality of your life as long as you can live it. I can't necessarily extend that lifespan, but it's about living quality wise, and that's what it does, for my patients.
Yeah, we're extending their health span, not their
Exactly.
lifespan. Yeah, that's
Exactly.
significant. What about, tell me about the influence of diet and exercise when it comes to hormone balancing.
Right. So diet and exercise play a big role. And again, I can put hormones or gas into a Ferrari, or I can put hormones or gas into a Geo Metro, one of my first cars, like I said, I'm a good old boy. Actually, my first car was a Pontiac. Anyway, so if you have a fine-tuned machine, hormones will run it better. And so diet and exercise, what all that does, so hormones are messengers, and you need the receptors to then take that chemical message and turn it into proteins, energy, things all throughout our body that make things go. So think of gas as being, gas and filling that tank as being the messenger that gets to the engine. And then you need a good engine to be receptive to that gas to run efficiently. And so when we are, eating sugar, when we're, excessive alcohol, when we're overweight, the receptors or the engine doesn't run as well. So it doesn't matter how much gas you put in. If you don't have the right pistons and the spark plug and the right engine going on, then it doesn't matter how much I put into people. They don't do as well. Now, will they feel better than what they did without? Yeah, they're going to feel a little bit better, but not as good as if I have them fine-tuned like a Ferrari.
So what is a realistic expectation? How much better am I going to feel? How much fatigue will be lessened? How much foggy thinking and cognitive fog is going to be lifted? Is it going to be just like I was 27 again?
Well, yeah, I cannot make you 27 again with that. What you have to look at is that we are not just hormones. So we're a product of our relationships. We are a product of our genetics. We are a product of our diets and exercise like we were talking about. And certainly we're a product of our hormones. So what influence do hormones have, and how much is that the deficit versus what we're born with or what we're doing to our bodies? And so do I get people who I put the hormones in and it's a lightning bolt and they tell everybody in their bunco group how great Dr. Dorr is and this is the best thing ever? And I get other people who are like, yeah, maybe I'm sleeping a little bit better. So what I tell people is, I do a happy dance when you're feeling better. But what I know with the studies that are out there is that this is going to prevent you from getting that early Alzheimer's, from getting that early heart disease, from getting that osteoporotic fracture. And if we get there early, we can prevent these things. It's not as noticeable, but it is about, and unfortunately, American medicine is about waiting for illness and treating it then. So what I'm about is I am here to treat your wellness. And what we're going to do is try and stave off these illness things that will have an everlasting impact on your health, your family, all those around you long term. That's what I'm after, is wellness treatment, not illness treatment.
And I can feel your passion about it. So I appreciate you being here and sharing that with us.
Awesome.
Thank you.